Everyone. I'm Enrico Gallazzi from Milano. Those are my disclosure. So we are speaking about osteoporotic vertebral fractures that are a very big problem. The incidence is very high, as well as the prevalence that goes up to 20% in females over 70 years old. And we know that vertebral compression fractures are associated with a progressive loss of weight, spinal kyphosis, pain, and in the end, a reduced quality of life. Also, the estimated annual cost to treat osteoporotic vertebral fracture are very, very high. In the United States, are between $12 to $17 billion per year. Actually, when we manage osteoporotic vertebral fracture, we start with our initial diagnosis that is based on clinical evaluation, X-ray, CT scan, and MRI. We usually start a trial of conservative treatment with rest, thoracolumbar brace, and sometimes pulsatile electromagnetic fields. And if persistent pain, we propose a surgery that could be either kyphoplasty, vertebroplasty, or in some cases, destabilization. But we also know that a percentage in between 20 to 35% of patients with osteoporotic compression vertebral fracture has a significant collapse of the vertebral body at 6 months. And this could lead to very big problems. For example, in this case, the collapse of the vertebral body led to a sagittal imbalance that was poorly treated in the beginning, and in the end, the patient had to underwent a fusion to the pelvis with a cage in L5S1 from anterior. There is, of course, a huge amount of literature identifying the risk factors for the progression of the collapse of the vertebral body. The most important one are the osteonecrosis, the posterior wall damage, and the middle column damage. And meanwhile, in the osteoporosis literature, it emerged a new score that is the trabecular bone score that has recently become one of the most useful tools to predict the occurrence of new fractures. And this score is very interesting because it highlights the importance of the bone microstructure in fracture occurrence. But in our opinion, this current approach has several limitations. First of all, the risk factor-based approach, as usual, cannot allow to a prediction for the collapse of a specific fracture. And the trabecular bone score, that is very interesting, is used to predict new fracture, and it's often calculated away from the fractured area. So our working question was, will the image analysis of the trabeculae of the fractured vertebra at the beginning will be predictive of the osteoporotic vertebral fracture collapse, and we designed a study aimed at exactly this. How did we do? Those are our inclusion criteria: diagnosis of a compression fracture, the availability of baseline diagnostic thin slice CT scan, no surgical treatment of the fractured vertebra, and at least 3 months of follow-up with the X-rays. We defined the collapse progression as an increase of more than 50% of kyphotic angle. We identified 30 patients that were analyzed with a matched pair analysis, with 15 patients non-progressive and 15 progressive. For both progressive and non-progressive patients, starting from the baseline CT, we identified the region of interest in the CT scan, including, of course, the fractured vertebra. We cropped the area, and we selected the axial slice stack of the index vertebra. We then uploaded in this software that is free to use. It's called ImageJ. We uploaded the stack of axial CT slice. We 3D reconstructed the vertebra and selected our area of interest, and in the end, we had the final slice processed for analysis. This software, of course, I said it's a free software available on the web, allows for the semi-automated analysis of the bone structure. There are already several papers published using this methodology in studying the bone. And the parameters we analyzed were the mean and the maximum trabecular bone thickness, the trabecular bone spacing, that is defined as the mean distance between the trabeculae, the bone volume ratio in the area of interest, and finally the trabecular anisotropy, that is the directionality of the trabeculae. More ordinated the trabeculae are, the closer the value is to 1. Those are our results. The baseline characteristics, of course, were very similar between the two groups. And those are the results of the image analysis. We found significant difference between progressive and non-progressive patients concerning the spacing, the trabecular bone spacing, that was higher in the progressive spacing, and the trabecular anisotropy, that with more disorientated and disordinated trabeculae in the progressive patient. We found no difference in the trabecular bone thickness and in the bone volume ratio, but there is a possible influence of the trabecular bone compaction in progressive fracture. In the image, you can see on the left side the reconstructed trabeculae of a non-progressive patient with a kind of ordinated trabeculae, while on the left you can see the more disorientated and disordinated trabeculae of a progressive patient. So in conclusion, the early identification of an osteoporotic vertebral fracture with the risk of collapse could allow for a tailor-made treatment approach. Patients with progressive osteoporotic fracture showed a different bone microstructure of the fractured body, and the most important parameters were trabecular bone spacing and anisotropy of the trabeculae. Thank you very much for your attention.